very common during first trimester and even early second trimester to be a little bit ambivalent about the pregnancy. Patients do tend to become very introverted at first during the pregnancy, focusing on themselves, that kind of thing. They may appear very passive to others. It's just almost their way of internalizing it and kind of processing the fact that their life is changing. Then they will go through a period where they accept that they are pregnant, and they'll start to make life changes associated with that. Two things that you do need to be mindful of is going to be the mood swings of pregnancy and the body image things that can happen with pregnancy. So we're going to cover mood swings first. So it is very, very, very common for pregnant patients to have mood swings. There is tons of hormones raging through their body, and so it is very likely that they may have what we call emotional lability, where they're fine and happy and excited one minute, and then they're not the next minute. They may be in tears. So that emotional lability is very common with pregnancy. With body image, there's a lot of changes that occur in a woman's body when she's pregnant. So that can be, some patients love it. They love the way their pregnant body looks, but for other patients, it may be harder for them to accept those body image changes. So we haven't covered your growth and development lecture yet, but when we do, we'll talk about anorexia. So if you have a patient that has a history of an eating disorder, pregnancy can be a very trying time for them because their body is going to go through changes, and we need to make sure that they have the nutrition that they need to support themselves and that growing fetus. So if you have a patient that has a history of any type of eating disorder, we need to be very open in communicating and making sure that they're gaining weight properly and that everything is proceeding, because it can be very overwhelming for them because their body is going to change so drastically during their pregnancy. All right, signs of pregnancy. So when we look at signs of pregnancy, you would think it would be, oh, well, I'm pregnant or I'm not, but, it's always got to be a little bit more difficult than that. So there's 3 different signs of pregnancy that you need to know. So your presumptive signs of pregnancy are going to be those subjective things that the patient is going to report to you that probably indicates that they're pregnant, but doesn't necessarily indicate that they're pregnant. So things that they might report to you would be breast tenderness, they're tired, they missed a period, they have nausea. So those are going to be presumptive signs of pregnancy. So just remember, presumptive has an S. S means subjective. So things that they could report to you that might support the diagnosis of pregnancy. Your probable findings are going to be objective findings. So they're going to be objective findings that a little bit more strongly support pregnancy, but not necessarily confirms it. So your probable, remember probable has an O, I guess positive does too, but probable has an O. Those are going to be your objective findings. So a positive pregnancy test would fall under a probable sign of pregnancy. Some additional findings are usually going to be things that the healthcare provider is going to do. The biggest one that HESI likes to test you on is Chadwick's sign. So Chadwick's sign is a bluish discoloration of the cervix itself. So when they perform pap smears and that kind of thing, they can actually observe that. So it is an objective finding. Other ones would be like Goodell's sign, where the cervix becomes soft or starts to soften, but the biggest one that HESI likes to test you on is going to be Chadwick's sign, of course, a positive pregnancy test, and that could be blood or urine. A positive sign, just think about positive being diagnostic. So you are absolutely pregnant, there's no doubt about it. So with your positive signs, ultrasound confirmation of the pregnancy, very diagnostic, you were definitely pregnant. Fetal heart rate auscultation, or fetal movement palpation, but only if it's done by the healthcare provider. So by far the most common thing that we do to determine if they are pregnant or not is just going to be an ultrasound. So an ultrasound would be diagnostic or a positive sign of pregnancy. Okay, so this is probably part of the lecture that gives students the most trouble as far as just learning different terms, because it is a lot of terms. So we're going to talk about this. So to calculate due dates, there's typically 2 ways that we do that. So if the patient knows their last normal menstrual cycle, then we can use Nagel's rule to give us a working due date. So Nagel's rule just states that you take the first day of the patient's last normal menstrual cycle, and you subtract 3 months and add 7 days and change the year if you need to, and that's their due date. Okay, so Nagel's rule, first day of their last normal menstrual cycle minus 3 months plus 7 days, change the year if you need to. The other way that we can confirm pregnancy and give a good working due date is going to be an ultrasound. So the ultrasound is going to use what the findings are in the uterus, and it's going to determine a due date based on that. So a early first trimester ultrasound is extremely accurate in determining due date. Now once you get outside of that first trimester, it's not as good because there's a lot of environmental factors or nutritional factors that can affect the growth of the baby, so it's not as accurate then, but it can be used regardless to give it some type of working due date. One thing that you do need to know about your ultrasound, for those early first trimester ultrasounds, they need a full bladder. So after that first initial ultrasound, they probably don't, but that first initial ultrasound, you're going to want them to drink and not void, because they're going to need to, the bladder kind of helps to push the uterus up a little bit so it can be seen easier. So Nagel's rule, ultrasound, 2 ways to calculate the due date on a patient. Then we're going to look at your OB history. So this is the way, like if you were to open up a prenatal record, this is the way we're going to delineate or abbreviate the OB history of a patient. So the term gravida means number of pregnancies regardless of outcome. So how many times has that patient been pregnant? And you can add different prefixes to this, so don't let that kind of get you messed up on a test. So a prima gravida means it's her first pregnancy. If they're a multigravida, it means they've been pregnant multiple times. But gravida is just going to be the number of pregnancies regardless of outcome. The term para means the number of expulsions of the uterus or the number of deliveries at or after 20 weeks. So the number of deliveries at or after 20 weeks regardless of outcome. So even if the mom had a stillborn at 22 weeks, that still counts as a para. But if she had a miscarriage at 10 weeks, that does not count as a para. So 20 weeks is your cutoff there. Has to be 20 weeks or greater. And because para doesn't tell you the whole story, then we have a TPAL system that kind of gives us more information about those pregnancy outcomes. So first I'm going to define them, and then we are going to practice one on the next slide. So the word term means 37 weeks gestation or greater. So 37 weeks and greater is going to be a term delivery. Your preterm delivery is going to be anything that is 20 weeks to 36 weeks and 6 days, because once they hit 37, they would be term. So 20 weeks to 36 weeks and 6 days. Your abortion is going to be a term that means anything less than 20 weeks. Now I know that the term abortion has a lot of connotation with that, but for our intents and purposes, it could be an elective abortion, which is what we typically think of as an abortion, or it can be a spontaneous abortion, which is the same thing as a miscarriage. So any pregnancy loss that's less than 20 weeks will be classified as that. So typically in the chart, if it's an elective or a spontaneous, there may be a specific note if it was an elective abortion. And then living is obviously how many living children they have. So here's what gets students, catches them a little bit off guard. So if you had a mom and she is now pregnant with twins, so she is a gravida 1 because she is currently pregnant. It's the only pregnancy she's ever had. And she delivers those twins. She is now a para 1. So it doesn't matter the number of babies that are inside the uterus. It's saying that that uterus has delivered 1 time. So twins, triplets, quadruplets, octuplets, whatever is going to be 1 para. But you would count them in the living section so that you can see that there were multiples. And there may be a side note on the chart as well. So let's practice this. So what I'm going to do is I'm going to read the scenario, and then what I would like for you to do is to pause and answer the questions, but I'm going to keep going. So you pause it, you answer the questions, and then you can start the video back. So Leslie's a 29-year-old patient being seen in her OB office with complaints of missing her period and nausea. She reports a history of an appendectomy at age 6 and knee surgery during high school for a sports injury. She reports that her last menstrual cycle was March the 20th. She has a 6-year-old that was born at 36 weeks due to preeclampsia, and a 3-year-old set of twin boys, or twins, that were born at 34 weeks by C-section. She also had a pregnancy loss at 8 weeks, and her urine pregnancy test in the office today was positive. So pause the scenario. You can answer the questions, but I'm going to keep moving forward. So the first question is, what information do you feel is important during this scenario? So for things for me that kind of jumped out was that she does have both presumptive and probable signs of pregnancy, so the likelihood is that she is pregnant. She's had 2 previous early deliveries and a miscarriage. So none of her babies have been full term, and she's had a miscarriage. So I know that automatically is probably going to place this pregnancy at a little bit higher risk. And she had a previous C-section, so that may change her delivery method for this baby as well. Number 2, based on the information provided, what presumptive and probable signs of pregnancy can you identify? So for presumptive, those are subjective, so I would identify that nausea and amenorrhea or missing her period would be presumptive signs. For probable signs, we did a urine pregnancy test in the office today, and it was positive, so that is a probable sign. Question 3, what additional tests would be ordered to confirm her pregnancy? I would anticipate the need for an ultrasound to confirm her pregnancy, and because we are thinking she is pretty early in pregnancy, we would need a full bladder for that scan. What due date would be assigned using Nagel's rule? So if we're using March the 20th, so that was the first day of her last menstrual cycle. So March 20th, if you subtract 3 months, it's going to get you into December. If you add 7 days, it would be the 27th, and there would be no need to change the year. So we could calculate that based on Nagel's rule, her due date should be December the 27th of 2020. When we do the ultrasound, we would expect that the due date that was assigned by the ultrasound would be very close to what we are seeing versus Nagel's rule. The last question says, record her OB history using the Gravidapara TPAL system. So I'm going to kind of tell you the way it's easier for me for testing purposes so you don't miss anything. So I usually write down that acronym so that you can give little tick marks as you go through the scenario so that you don't miss anything. Don't forget, if they're in the office and they are currently pregnant, that is going to count as a gravida because they are currently pregnant. So with her, she is currently in the office. We're going to assume that she is pregnant, so that would be 1. She has a 6-year-old, so that is number 2 pregnancy. She has a 3-year-old set of twins, that would be 3. And then she had a pregnancy loss at 8 weeks, which is a 4. So that makes her a gravida 4. For your paras, the 6-year-old was born at 36 weeks, so that would count as a para. The 3-year-old twins were born at 34 weeks. That would count as a para. The 8-week loss would not because it's less than 20 weeks. So that would make her a para 2. And now you can break it down even further into the TPAL system. So for term deliveries, that would have to be deliveries at 37 weeks or greater. So the 6-year-old was at 36, so that's going to be a preterm. And the 34 is going to be a preterm because it is less than 37. So term 0, preterm 2. And because her miscarriage was at 8 weeks, that is less than 20 weeks, it will count as an abortion. And she has 3 living children. So based on our system, we can record in her prenatal record currently that she is a gravida 4, para 2, term 0, preterm 2, abortion 1, living 3. With a side note that says she has twins born by C-section. I know that's a lot of information, but I promise we will continue to practice that in our live session as well. So, and there's some extra practice posted on Canvas also. All right, nutritional guidelines for pregnancy. So just some general things that you need to be mindful of. Caloric intake during pregnancy does need to be increased. We usually increase that by 300 to 500 calories per day. Those do need to be nutritional sources of calories, not a Big Mac and a milkshake. If they are adolescent, we do typically go with the 500 because remember, an adolescent is still growing themselves. So you want to make sure that they do have an adequate calorie intake. For weight gain and BMI, your weight gain is going to be based on what their BMI is. So what I always tell students is to learn what it should normally be if everything was perfect, and then you can adjust for either side of that. So a normal BMI is going to be between 19 and 25. So for a patient that has a normal BMI, they should gain between 25 and 35 pounds during the pregnancy. If they are underweight, so if their BMI is less than 19, or you can tell by their height and weight that it's going to be less than 19, they need to gain a little bit more. And if they're overweight or obese, they're going to need to gain a little bit less. So normal weight gain, 25 to 35 pounds for a patient that is normal BMI, a little bit less if they're overweight, a little bit more if they are underweight. Some safety considerations as far as nutrition. We do want our patients to obviously eat very healthy. They need to avoid alcohol. They need to have plenty of water intake because the uterus is a muscle. If it gets dehydrated, it gets very, very upset and starts contracting, which we don't want to do early in pregnancy, especially when we live in the South. So water intake is going to be a huge, huge, huge thing that we need to teach our patients about. We do want them to avoid high mercury fish like shark, swordfish, and ahi tuna. It is okay for them to have limited amounts, like 2 times per week, of light tuna or salmon, catfish, shrimp. Those type things are fine. They just need to eat those in moderation. So usually 2 times a week is completely fine. They also need to avoid eating hot dogs and lunch or deli meat that has not been reheated. So I don't know why you would want to eat a cold hot dog, but if that's something, because pregnancy changes your taste. So if they're wanting hot dogs, lunch meat, deli meat, they need to warm it because it can harbor a bacteria known as listeria, which can cause some problems during the pregnancy. They also need to avoid feta and blue vein cheeses. Meat spreads like Spam. They need to make sure they wash their fruits and vegetables really well also. We also want to make sure that they are getting adequate amounts of iron and folic acid. Folic acid helps to prevent neural tube defects, but it also can cause anemia in the mom. So make sure they have plenty of folic acid. And they also need to increase their iron in their diet because that is very important, not only for moms for their red blood cell count, but it also is very important for fetal growth and brain development in the fetus. Your prenatal vitamins typically have iron added to it, but it's not uncommon for us to add an additional iron supplement or folic acid supplement above just the normal prenatal vitamin. Some special considerations or things that you need to be mindful of would be patients that are on a gluten-free diet. Your gluten-free patients may be deficient in several different things like iron, vitamin B, calcium, fiber. So we need to make sure that if they're on a gluten-free diet that we are giving them other nutritional sources to make sure that they have adequate intake of all of their folate, their vitamin B, their iron, calcium, those type things. Your lactose intolerant patients may be deficient in calcium. So if they cannot tolerate milk products and those type things, then we need to make sure that they do know that there are other foods that are high in calcium like almonds, peanuts, sunflower seeds, broccoli, kale. So there are other options that we can offer them to help maintain an adequate calcium level. Your vegans and vegetarians do not eat meat or meat products or animal products. So they can be deficient in several different areas. protein and iron is going to be a big one. So if you do have a patient that the test question says, so if you want to know how to apply this to a application question, if you have a patient that comes in that's anemic and they're pregnant and they're a vegetarian, then you're going to need to educate them about sources for iron that would not be animal based. So if you're looking at iron, that would be like spinach and legumes, kidney beans, lima beans, those type things. So those would be good options for somebody that's a vegan or a vegetarian. For pica, I put that on here because I wanted to kind of go over that for a couple different reasons. So pica is going to be defined as a craving for non-food substances. Here in the South, the biggest ones that we see are going to be white dirt or white clay, cornstarch, those type things that don't have any nutritional value. And it can be one of two things. Sometimes pica is seen because there is a nutritional deficit that the patient is trying to fill, so their body starts to crave these things. However, in the South, it is very common in certain ethnic groups for pica to be something that's kind of a culturally accepted norm. So just be very mindful if you're addressing a patient about this, that it may be something that they are not very open to talking about, because there can be a little bit of a stigma to it if they're eating white dirt or cornstarch or that kind of thing. So just make sure that if you're approaching a patient about this, that you're approaching it from an issue or from a caring place, and it's non-judgmental, and it's talking about things that they need to do to make sure that they are adequately providing for the growing fetus inside. A lot of these patients are chronically anemic, and so there may be some things that we can do, adding iron to their diet, changing their diet a little bit, that may actually help with these cravings. But do know that it can also have a cultural component here in the South. Alright, so for your OB assessments, these are going to be things that are either done routinely or are going to be done during some of their prenatal visits. So we're going to start from the top and go to the bottom. So obviously we're going to assess weight at every prenatal check. We're going to look to see if they're gaining weight, if they're gaining too much weight, or if they're not gaining enough weight. So if they're underweight or they're not gaining enough, that may be education that needs to be provided about increasing calorie intake. If they have gained too much, then it may be education about nutritional intake, and maybe they thought they could have 1,000 calories extra a day, but really they only need the 300 to 500. We're also going to look at vital signs. Remember, we talked about this a little bit earlier, that the blood pressure should never elevate above the established normal baseline. Their heart rate may go up slightly, their respiratory rate may change a little bit, but their temperature and their blood pressure shouldn't really be above their established norm. Your fundal height. So the term fundus means top of the uterus, and you'll see it in different parts of these lectures for different reasons. So your fundal height is basically going to be a measurement from the symphysis pubis to the top of the uterus. So if you see both of those pictures, the top picture showing you how to measure it, even though that's usually done by the healthcare provider, and the bottom picture is just kind of showing the week's gestation and how it relates to the fundal height. So the fundal height will be assessed at each prenatal visit. And the really interesting thing about the fundal height is it's a pretty quick way, and it gives us a lot of valuable information. So if you measure the fundal height on a patient that has one single baby inside, their fundal height in centimeters should correlate with their week's gestation. So if they are 20 weeks pregnant, their fundal height should be around 20 centimeters. Now, obviously, if they have twins or triplets or 8 babies in there, that kind of goes out the window. We still measure it to make sure the babies are growing. But if it has one baby inside, very, very easy way to just do a spot check. So the way that could be put into an application type question for a test would be to tell you that the patient is 34 weeks pregnant, but their fundal height is measuring at 28 weeks pregnant. What does that tell us about that baby? It tells us that that baby is not growing properly, and there's follow-up that needs to be done, because that would not be a normal finding. If that mom was 34 weeks pregnant and her fundal height is 34 centimeters, then there's not a nursing action that needs to be done. That is an expected finding. So when you're studying these things, think about how you could apply that or how you could put it into a test question. They will also do fetal heart tones, obviously once they're past the point where they should have fetal heart tones. And your fetal heart tones are going to be done by Doppler, which is basically just a little handheld ultrasound type machine that just picks up the tones, and you can count them that way. So, you know, the new ones, you just put it on there and it'll actually tell you what the rate is. But do remember that your fetal heart tones are going to be faster. They're hard to count. So if it's not giving you the reading and telling you how fast it is going to be much faster than ours. So it should be 110 to 160, somewhere within that range. So fetal heart tones can be Dopplered. Remember we said earlier between 10 and 12 weeks. So at that point, that would become a standard practice during your prenatal visits. We do a urinalysis at every office visit as well for a couple reasons. One is because we know patients that are pregnant are higher risk for UTIs, and they don't typically have the normal symptoms of like burning and stinging that would tell them, hey, I need to have this seen about. So we check it with each office visit to make sure they don't have a UTI. And then we also look at that urinalysis to make sure there's no protein in the urine. And that's going to be something that we'll talk about much more in depth next semester with your preeclampsia. But they shouldn't be spilling protein in their urine. So that would be a red flag that would need to be reported to the physician. Cervical exams are not done with each prenatal visit, but